Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 19, 2025. This editorial is on 3 articles in the New England Journal of Medicine, 2 original articles, and one accompanying editorial. The original articles are titled, the first one is titled Aficamten or Metoprolol Monotherapy for Obstructive Hypertrophic Cardiomyopathy. The second original article is Mavacamten in Symptomatic Non-Obstructive Hypertrophic Cardiomyopathy. And the editorial is titled Expanding the Role of Myosin Inhibition in Hypertrophic Cardiomyopathy, A Tale of Two Conditions. Published August 30th, 2025. Obstructive hypertrophic cardiomyopathy affects millions. Beta blockers are standard, yet data is limited. Aficamten is a cardiac myosin inhibitor which reduces contractility and LV-OT, left ventricular outflow tract obstruction, and improves symptoms. This MAPLE hypertrophic cardiomyopathy study, MAPLE-HCM study, was a randomized double-blind, double-dummy comparing Aficamten 5 to 20 milligrams versus metoprolol 50 to 200 milligrams for 24 weeks. 175 patients comprised the international study cohort, mean age 58, 58% men, 88 were assigned to Aficamten and 87 to metoprolol. The primary endpoint was increase in peak VO2, peak oxygen uptake per mil per kg per minute. The secondary endpoints, NYHA class, Kansas City Quality Life Score, NT-proBNP, left ventricular outflow tract gradient, LA volume index, and LV mass index. What did they find? Peak VO2 increased by 1.1 in the Aficamten versus a decrease of 1.2 in the metoprolol group. The delta was 2.3 mils per kg per minute. P-value less than 0.001. Greater improvements in NYHA class, Kansas City Quality of Life questionnaire score increased by 6.9 points. LVOT gradient decreased by 40.7 millimeters of mercury in the Aficamten group. There were improvements in NT-proBNP and LA volume index. No significant difference in LV mass index. Transient decrease in left ventricular ejection fraction in one patient on Aficamten. Limitations of the study, just 24-week duration. Findings may not generalize to other beta blockers or longer-term outcomes. Conclusion, Aficamten outperformed metoprolol monotherapy for functional improvement and hemodynamic relief in obstructive hypertrophic cardiomyopathy. Mavacamten was evaluated in symptomatic non-obstructive hypertrophic cardiomyopathy, that is with no left ventricular outflow tract obstruction. Mavacamten is a selective cardiac myosin inhibitor hypothesized to improve myocardial energetic efficiency. This was a randomized double-blind placebo-controlled trial enrolling 112 patients with symptomatic non-obstructive hypertrophic cardiomyopathy. Duration, just 16-week treatment phase. All patients had an ejection fraction, left ventricular ejection fraction equal to or greater than 55%. NYHA class 2 to 3 symptoms. NT-proBNP above the upper limit of normal. The primary endpoint, change in Kansas City Cardiomyopathy Questionnaire Clinical Summary Score, powered for patient-related outcomes, not exercise. What did they find? The mean change in the Kansas City score was an increase in 9.1 points in the Mavacamten group versus 4.0 in the placebo group. The delta is 5.1, p-value 0.029. NT-proBNP and cardiac troponin I decreased significantly in the Mavacamten group, p-value less than 0.001. Secondary endpoints, hypertrophic cardiomyopathy symptom questionnaire, EQ5DDL at 5L favored Mavacamten. LVF stable, decreased by 2.3% in the Mavacamten group versus 0.1%. Limitation of the study: short duration, 16 weeks, small sample size. The sample size is 112. Trial was not powered for clinical events or mortality. Conclusion: Mavacamten offers symptom relief and biomarker improvement in non-obstructive hypertrophic cardiomyopathy, a potential shift in management. In the editorial titled Myosin Inhibition and Hypertrophic Cardiomyopathy, a Tale of Two Conditions, it commented that the obstructive and non-obstructive hypertrophic cardiomyopathy have diverging therapeutic landscapes with different unmet needs. The editorial summarized the findings of the MAPLE-HCM and the ODYSSEY-HCM. It said that the Aficamten showed superiority over metoprolol for obstructive hypertrophic cardiomyopathy, increase in peak VO2, decrease in LVOT gradient. In the ODYSSEY-HCM, Mavacamten failed to improve exercise capacity or quality of life score in non-obstructive cardiomyopathy, increased adverse events. Editorial cautions: short duration, selection bias, lack of head-to-head data, and reduced EF in some patients. The editorial concluded, myosin inhibition is transformative in obstructive cardiomyopathy, but not non-obstructive cardiomyopathy. And non-obstructive hypertrophic cardiomyopathy needs new targeted therapies. This is in a nutshell the findings of the recent MAPLE-HCM and the ODYSSEY-HCM study. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom.